The next speaker is going to be Professor Sunil Wimalawansa. He's again joining us in a pre-recorded version of his speech. And he will be available to answer your questions at the end of his presentation. And he's going to talk us on therapeutic options in the management of postmenopausal osteoporosis. Over to you, Prof. And while you wait for his speech to start, you can probably go through his elongated CV where he has a wide knowledge on this current topic. Over to you, Prof.
Hello and welcome to the Sri Lanka College of Endocrinology Pre-Congress Osteoporosis Symposium, which is collaborated by Sri Lanka Orthopedic Association. In this presentation, I'm going to discuss about the advances in the management of osteoporosis. The learning objectives of this session is about understanding the basic concepts related to osteoporosis, osteoclast, osteoblast cell biology, mode of action related to the new therapies, and the summary of management of osteoporosis. Presently, do not have any conflicts of interest related to this presentation. Customarily, most people believe that osteoporosis fractures commonly occurring in the spine, hip, and wrist, where there's a mostly trabecular bone. However, but a couple of years ago, in the American Association for Clinical Endocrinology, we published a paper, our update on osteoporosis in the endocrine practice, which indicated that at least 40% of the osteoporosis fractures occurs outside the hip, wrist, and spine. Therefore, the clinician should pay attention to these extra common sites where the osteoporosis fractures occur. For example, the rib fractures quite commonly occur in those who are on long-term corticosteroid therapy, and we should not ignore those fractures because one fracture will beget to additional fractures. Why should we worry about this asymptomatic disease, the osteoporosis? There are a number of good reasons. Firstly, about 1.5 postmenopausal women in US will get admitted for orthopedic intervention due to osteoporotic fractures every year. This is more than the combination of the heart attacks, strokes, and the breast cancers put together. In addition, the lifetime risk fractures in 50-year-old women is more than 50%. That means 1 in 2 women will develop fractures during their lifespan. So this is an enormous socioeconomic burden to the society and the families as well as individual, and therefore physicians have the responsibility to intervene to minimize this occurrence of fractures. This is one such example where this is one of my aunts has lost about 16 inches of height over a 5-year period. As you may see, that can lead to multiple clinical problems, so as social and socioeconomic problems and communication issue, breathing, etc. So these can be prevented by proper interventions. This is another patient who developed multiple vertebral fractures following high-dose corticosteroid therapy for her chronic lung disease. Now, this patient also developed a Dowger's hump and loss of height. And in addition, the thoracic cavity is now compressed, seeking pulmonary advice, and the abdominal cavity is compressed. Therefore, she also go to gastroenterologist. Unfortunately, some of these specialties also prescribe drugs similar to osteoporosis, similar to glucocorticoids that can worsen the bone loss and causing more problem for patients like this. Here are some key factors contributing to osteoporotic fractures. The most important out of the lot is the age, aging population. The higher the age, lower the bone strength because it deteriorates the microarchitecture in the bone, both cortical as well as a trabecular bone. Also, having one fracture, it's increased subsequent fractures by 20% on annual basis. Finally, the secondary causes of osteoporosis, like the glucocorticoid and other agents, as well as coexisting primary hyperparathyroidism, myeloma, etc., will increase the bone loss and fracture rates. This slide summarized the 10-year fracture probability against a T-score taken as a minus 2.5 as a cutoff point. You can see that 70 to 80-year-old females actually have about 5 to 6-fold increase of fracture risk compared to 50-year-old, even though they will have the same minus 2 standard deviation of T-scores. So T-scores alone is in consideration is kind of useless unless you consider the age and other fracture risk as well. What you're looking at is osteoclast under the microscope, and it's one of the largest cells in the body. It's a multinuclear giant cell. And we did these studies going back many years ago when I was a senior lecturer at the Royal Postgraduate Medical School in mid-1980s. So this cells is capable of resorbing bone very actively and move from place to place. Here's an example of using what we call is osteoclast bone resorption assay using devitalized polished thin bone slices. On the experimental condition, on these bone slicers, we lay the various osteoclasts, isolated osteoclasts. Then we add the components to see whether that, in this case, nitric oxide donors, whether they increase or decrease the osteoclastic activity in comparison to the controls. What you see here is osteoclastic pits, where you can measure the surface area, not only the surface area, but also the depth. And the computers will calculate the exact amount of the bone resorbed by these osteoclasts per given time period. So we can actually quantitate the effectiveness of this agent or the increasing or decreasing osteoclast-mediated bone resorption. This is a scanning electron micrograph of trabeculae. You can see that the osteoclasts are eating away some bones here. And when this goes through the trabeculae, it gets disconnected. Once the trabeculae get disconnected, it participates in no way to participate in the bone stabilization or weight-bearing activity. In fact, it becomes useless in that point of view. So idea is to prevent these microfractures happening. Here's a larger version of that showing the osteoclastic bone resorption. And again, if we manage to go through and through to separate the trabeculae, this particular trabeculae become worthless. This slide, what you see is a normal vertebrae, is a cross-section, and you can see a honeycomb appearance of very tightly compact, but stronger vertebral sample here. In contrast, the osteoporotic bone is size, and here what you see is the loss of trabeculae, particularly the horizontal trabeculae, that disproportionately reduce the bone strength in these patients. What I'm going to show you is a three-dimensional view through a confocal microscopy. What you are looking at is the honeycomb appearance of the bone, which is stronger and the least weight because it's empty spaces. Comparison to this osteoporotic bone, you can see that the horizontal trabeculae are lost, and therefore the bone strength is dramatically lost in these patients. In estrogen deficiency, including oophorectomized patients, That is increased bone resorption leading to osteoclast pits, and these osteoclasts are overactive and therefore they make more pits. But since osteoblastic bone formation are also reduced, and these will get only partially filled, eventually leading to less bone mineral density and lower bone strength. The slide basically summarized the remodeling intensity as uh, depicted here by activation frequency, number of per year, and it also goes in parallel with the remodeling of the bone. Compared to premenopausal state, you can see that the osteoporosis, the bone turnover has gone up significantly, and as depicted in the bone turnover markers, either in blood or in urine that you can measure. The goal of treatment of anti-osteoporosis therapy is to bring down this activation frequency back to premenopausal levels. In this slide, the section, what you stain with HNE, what you can see is some microfractures here, multiple microfractures. In day-to-day activities, and you and I, we develop a few hundreds to few thousand of these microfractures, and eventually these will get healed during our sleep. What happens generally is these microfractures are invaded with osteoclasts, as I showed in the previous video, and then they produce this microcallus formation and attempted to heal this damaged area. In most cases, particularly in the young, this gets successfully repaired, but in the old age, it is not. Here's a cartoon where what you can see is that these monocytes from the blood is attracted to the damaged site of the skeleton, where you can see they are converted into osteoclast, and they start eating up the bone, basically they're eroding the microfracture, followed by osteoblast comes in and fill in those gaps with osteotissues, and eventually these osteotissues gets calcified and the problem solved. Unfortunately, using the techniques like bone mineral density, ultrasound, etc., there's no way one could identify the bone strength. Instead, you can use the quantitative computerized tomography or MRI to generate the geometry as well as bone density and indeed the bone strength. You can calculate it through a technique called finite animal analysis. It's an engineering mathematical modeling. In the picture, you can see the compared to the normal bone, in the osteoporotic bone, it's a very much sparse trabecular bone, and therefore it's weaker and easy to get fracture across the neck of femur. So let's look at the concept of managing postmenopausal osteoporosis. Firstly, the identification and elimination is a secondary causes, is a must, and then to assure that patients are getting adequate nutrition, particularly the calcium and vitamin D, and some physical activity, especially walking, that provide the weight-bearing activity to stimulate the osteoblast to generate more collagen and osteoclast to eat less bone at the same time. Management is completely not completed unless you advise about the lifestyle changes, prevention of falls, and injuries. So these four elements are essential part of the managing osteoporosis by all physicians. Unless you have completed all these four in every patient, you should not even think about writing a prescription for osteoporosis. That is perhaps considered as unethical. And only a small number of patients, what you see, actually requiring the pharmaceutical therapy, provided that you have attended properly to the above four conditions. In many patients, is sufficient to prevent bone loss and preventing fractures. However, in the selected patient, you have to decide what is the most cost-effective agent available to treat, to lose prevention of bone loss and recurrent fractures. So here, what you're seeing is a common causes of secondary causes, such as glucocorticoids and any type of anti-cancer treatment. estrogen deficiency status, including the surgical oophorectomy and disorders of the eating, particularly the malnutrition. Gastrointestinal disorders are well known to reduce the absorption of minerals, calcium, phosphate, and indeed vitamin D. So this is like celiac disease, inflammatory bowel disease. Also, post-operative conditions like bariatric surgery will have a major effect on imbalance of the micronutrient, which can cause osteoporosis as well. And identify and eliminate the alcohol abuse and smoking so as a parathyroid overactivity, which is rare, but once identified, overactive parathyroid glands should be removed in most cases, to regain the balance. The genetic disorders related to bone and collagen formation are rare, but indeed existing. One of the commonest is the osteogenesis imperfecta. In normal medical practice, the physicians or general practitioners probably will not even see a patient with osteogenesis imperfecta and other genetic bone disorder during their career. However, in places like our clinics, which are not only tertiary but quaternary referral practices, where we have about 45 million people, our referral base, we do see genetically driven bone diseases virtually every week. For example, we have families, about 60 families of patients with osteogenesis imperfecta, consisting over 250 patients. So what are the non-drug therapies for osteoporosis? As I said before, unless there's a force and injury, fractures may not happen. So it is important to prevent the postural hypertension, for example, by giving antihypertensive therapy, especially the diuretics or sedative use, excessive use of sedations. What we advise all our patients is to, when they get up from the chair or from a bed, to stand up at least 20 to 30 seconds until they get balance and not having any dizziness, so that we can minimize the falls. For those who are malnourished, whether it's a protein, mineral, or vitamin, that should be supplemented, because that itself can have an effect of improving the balance and preventing falls and fractures. Calcium supplementation, while we prefer to have a dietary sources, could be given as a single tablet, so either 400 or 500 milligrams on a daily basis after dinner. So what are the basic concepts and principles of osteoporosis drug management? There are many pharmaceutical agents available to lower the fracture risk, either by reducing bone resorption or by enhancing bone formation, which we'll discuss in a minute. But bisphosphonates are the most commonly used anti-osteoporosis agent. In fact, worldwide, close to 400 million people are using bisphosphonate on day routinely. These agents are known to reduce the vertebral fractures between 50 to 70%, but hip fractures by about 40%. However, it's noteworthy that these are all relative fracture reduction compared to a placebo or another agent. If you look at the fine prints on the actual or the absolute fracture reduction of any of these agents, we're talking about between 1 and about 3 to 4% is the maximum. It's a very small amount in the absolute fracture reduction. So how do you select patient for therapy or identify people who do not need treatment? In this regard, what's most important is a history and physical examination that will give you a clue to do the next step, whether a patient needs investigation or anything else. This will be clearly aided by a fracture risk calculator. There are multiple of risk calculators available in the internet and printed version. Whether you use the FRAX or any other fracture calculators, as I show in the next couple of slides, outcome basically the same, very little different between these two. So fracture risk score can be used to identify when the patient should be further investigated or treated with cost-effective medication. In these circumstances, there's absolutely no point doing bone density measurements in this patient. It's basically a waste of money and time, where the same information can be obtained through fracture calculator, risk calculators. Here's one such we developed about 10 years ago, which was validated by the Menopause Society in Sri Lanka about a few years ago. Now, what you look at is the physician or the nurses can fill up these boxes by asking questions from the patient or looking at the chart. And at the end of the page, there is a total score you can add it up. So those who are with scores less than 18, this particular fracture is a calculator, there's no therapy indicated. What they need is a healthy guideline, a balanced nutrition, etc. However, in the intermediate group with the 19 to 21 fracture risk score, they do need a basic investigation, fall prevention advice, and perhaps review in 3 to 4 years down the line. Whereas those who score more than 30 are at a higher risk of fractures. Therefore, they could require specific investigation related to the bone loss and potentially evaluation for therapy. So this include, for example, like your 24-hour urine calcium, the serum electrophoresis to exclude myeloma, and PTH to exclude hypoparathyroidism, etc. And essential for them to have a fall prevention advice, muscle strengthening and balance training exercises, and if indicated, anti-osteoporosis therapy, some of which are illustrated in this particular slides. In addition to the bisphosphonate, there are estrogenic agents such as raloxifene, which is the anti-estrogenic mimic, and then the anabolic agents like teriparatide and abaloparatide, and the injectable rank L inhibitor, which is denosumab, is available. And finally, the sclerostin inhibitors, which we are going to discuss a bit more details in a few minutes. So what are the anti-resorptive agents available? In addition to estrogen, raloxifene I already mentioned, which is a good drug if the patient is having breast cancer or the history of breast cancer or the family history of breast cancer, to reduce the recurrence as well, using raloxifene, at the same time reduce the bone turnover. So it has a dual effect. Bisphosphonate, you are all familiar with, and calcitonin is rarely used for osteoporosis, except in the case that acute fracture syndrome, particularly from the vertebral fractures, one can prescribe the 1 vial of intranasal calcitonin to be taken in alternative nasal spray, but 2 to 3 times a day for about 3-4 days by the time the vial will be over. The goal of here is actually reduce the pain dramatically within the first 24 hours. Therefore, you can ask the patient to mobilize the patient to prevent other complications such as a DVT. The other osteoclast inhibitor is a denosumab. We also will going to discuss a little bit on that. These are the agents available in Sri Lanka, and you all are prescribing for most part. And as I said, raloxifene is only indicated for those who are with breast cancer, and that is because it's a much weaker agent compared to bisphosphonate. And calcitonin really should not be used for osteoporosis treatment or prevention, except as indicated to relieve bone pain specifically. I have been a medical educator and professor of medicine for now almost four decades. Therefore, I generally like to ask some questions when you have a presentation like this. Hope you don't mind. Here's the first question. Which of the following drugs has been shown in clinical trials to reduce the risk of hip fracture? Ibandronate, raloxifene, denosumab, or teriparatide? The answer is the denosumab. All three other drugs has got an effect factor reduction effect, but only on a trabecular bone containing vertebrae, not on the hip. Bisphosphonates have a high affinity or avidity to bone mineral. Therefore, this stays in the bone skeletal tissue for months to years. The weaker bisphosphonate, like risedronate, comes out of the bone between 7 to about 9 months, whereas alendronate and risedronate will stay in the skeletal tissue for many, many years, up to 10 years or even more. Therefore, these agents are administered infrequently. However, when indicate long-term bisphosphonate or denosumab, one had to be space it after about 5 years to avoid drug-induced major complications, osteonecrosis of the jaw and atypical femoral fractures. The next question, drugs in which of the following classes bind to bone and remain effective for months to years even after discontinuation of therapy? The answer is bisphosphonate. All other drugs are transient and their half-lives are very smaller compared to long-acting bisphosphonates. So with reference to bisphosphonate, which causes major gastrointestinal adverse effects, like GI bleeding and occasionally even the perforation of the stomach, etc. So how can we prevent this is happening? It's the switching over from an oral agent to an intravenous preparation, mainly because when you avoid the oral route, the gastrointestinal epithelium does not get exposed to bisphosphonate, therefore no irritation or ulceration. None of the other areas, alternatives are applicable here. Next category is the receptor activator of nuclear factor kappa B ligand, what you call a rank ligand. The only drug available under this category is denosumab. Denosumab is a monoclonal antibody raised against rank ligand, which will show the mechanism in the next couple of slides. It's a potent inhibitor of the osteoclast development as well as activation of osteoclast and bone resorption. It is administered every 6 months on the subcutaneously, and anti-fracture effects denosumab are a little bit better than bisphosphonate, but in the same category. However, the difference is when you stop denosumab, its efficacy rapidly loses after 7th month of administration. Therefore, if you want to continue with the denosumab, it must be continued on a 6-monthly basis. So rank ligand is exclusively produced by the osteoblast within the bones and act on osteoclast to activate bone resorption. Similarly, rank ligand bind to the monocytes and the precursors of osteoclast to generate the multinucleated osteoclast cells and attract that to the bone surfaces and activate their bone resorption activity. Denosumab is to actually neutralize the rank ligand in the circulation and the local milieu in the bone area, and thereby prevent activation of the osteoclast. Similarly, it also neutralizes the rank ligand, therefore there won't be any excess cells coming into the bone to generate osteoclast or its activation, thereby markedly reduce the bone resorption activity. So let's move on to the anabolic agent for skeletal growth. There are 2 drugs available. One is the teriparatide, the PTH analog, and second one is abaloparatide, which is a PTH-related peptide analog. They both work on the same receptor, PTH1 receptor, and present in osteoclast cells. In fact, there are about 6 million receptors on each osteoclast. So the absolute target for this compound. Both drugs are given by subcutaneous daily or every other day injections. So intermittent administration of these PTH analogs increases the bone formation dramatically, and because the increase of bone formation and the subsequently bone resorption also increases, therefore the continuation of PTH analog for a longer than 18 months to 2 years is going to be counterproductive, in addition to the potential adverse effects. So therefore, the maximum duration of these agents are given is 2 years. That must be followed up by the anti-osteoclastic agent like denosumab or bisphosphonates. This slide shows the when you administer PTH or PTH analog and then give the tetracycline to a man or a woman who's taking the medication, you can see the enhanced bone formation or double labeling in the bone surface. And in the given the placebo, there are some lighting up, but nothing compared to those who are on the PTH. So basically showing that it has got a major effect on osteoblast-mediated bone formation. This question is about following adverse effects of anti-osteoporosis drugs have been well documented, except one of these. First, 5 adverse effects are well known related to bisphosphonate, and the last one, there's no indication from any of these drugs mentioned that causes bone marrow suppression. The last category of new drugs within for osteoporosis is sclerostin inhibitors, what you call the Wnt inhibitors. I'm going to show some data related to romosozumab, which is anabolic, has major anabolic effect on the skeleton. It is also an anti-osteoporosis agent, reducing the osteoclastic activity and at the same time increase osteoblastic activity. In other words, it has a dual effect. Romosozumab induces bone formation and suppresses bone resorption. So it reduces all type of osteoporosis fractures, vertebral, non-vertebral, and hip fractures. However, one need to be careful as it has the tendency to increase cardiovascular risk, and therefore we suggest to avoid in those who are at a higher risk of cardiovascular disease. This slide summarizes some studies comparatively to the placebo in the alendronate, teriparatide, and blue is from the romosozumab on the lumbar spine on the left, and the total hip BMD increases. As you see that monoclonal antibody of romosozumab has a major effect on the bone mineral density, especially in the trabecular bone containing lumbar spine compared to the hip, but it is predominant compared to other agents. So what is sclerostin? It is an activator of osteoclast apoptosis, a nuclear factor kappa B ligand, a parathyroid hormone analog, or an inhibitor of the Wnt B catenin signaling pathway. The answer is indeed the last one. It is a part of the Wnt B catenin signaling pathway, which is specific to osteoclast system. The next 3 slides, I'm going to summarize the recent randomized controlled clinical trials related to new compound in comparative basis. First slide shows the denosumab right on the green line compared to zoledronate, and indeed comparison to alendronate. So this is a very straightforward slide. What you're looking at is the changes of BMD in the y-axis against a time up to 9 years. Second slide, I'm going to show you like kind of a little complicated slide. If you start with the bottom line, it's a green one which shows the PTH converted to denosumab after 2 years of treatment. Second one is the denosumab treatment, then given PTH treatment, which actually loses all the benefits. And third one, in this case, combination of denosumab and teriparatide, followed by denosumab. However, you don't need to have any combined therapy to get that. You can give teriparatide alone, or abaloparatide alone, followed up by the bone resorption agent like bisphosphonate or zoledronic acid or denosumab, you get the same benefit like in this green. This slide is straightforward, giving the romosozumab, which is osteosclerosis inhibitor, in this case 48 months. But as you see that the difference between the 12 months administration and 48-month administration is minuscule, change of bone mineral density or the bone strength. So we recommend that is to stop this medication after 12 months and then continue with either zoledronic acid or denosumab to maintain benefits. It also much less costly and less side effects in that way for the patient. This is a forest plot I just put together to show you that there are hierarchy of effectiveness of various agents in vertebral as well as non-vertebral fractures. By the way, these slides presentation will be converted to video and will be uploaded into the college website soon. So you'll have time to go back and review these slides leisurely. And so don't worry about if I run a little too fast right now. This is an important slide. It's important to decide what type of treatment which best suits a given osteoporotic patient. What you're looking at is the cortical microarchitecture. In the antiresorptive is preserve the cortical thickness but decrease the cortical porosity. So basically, it's a pharmacological effects and look kind of away from the physiology. Whereas anabolic agent, it increase the cortical thickness and also increase the cortical porosity, which is somewhat similar or towards a physiological effect one we see in the premenopausal women. So this kind of concept you can think about and apply when you are deciding what's the best therapy for a given patient. So bisphosphonate is the most cost-effective and most widely used agent worldwide. Despite the difference of BMD, anything varies from 2% to about 10% increase of BMD in a year, different medication, the fracture risk reduction doesn't change. So some people will say, so what? We'll use whatever is available. In fact, it's true, because what they really end up with is not the change of BMD, but the fracture risk reduction. However, the anti-resorptive agent could have two serious adverse effects. One is osteonecrosis, the jaw, and the second one is the atypical subtrochanteric femoral fractures. So let me show you a couple of examples, two slides of examples of cases of severe osteomyelitis of the jaw. What you're looking at here, the blue arrows, is a white area, is exposed, in this case mandible, and here the exposed is the maxillary bones. So these patients do have major problems, pain, difficulty eating, etc. And virtually all these sites are infected with the, most commonly it's a common cell bacteria, which is the Actinomyces israeli present in the mouth. And 98% of the cases, it has been cultured from these lesions. So what happened here is actually you get a osteonecrosis, but that is due to cut off the blood supply due to edema. So you get osteomyelitis, lead to osteonecrosis, and it can spread as long as there's no blood supply around it. Same principle apply when you're treating this patient. If you get an oral surgeon to clean up this thoroughly, actually it can make it worse. Because what happened is this ischemic area going to get worsened and the extension of the lesion going to get worse and internal spread of Actinomyces israeli bacteria. So the surgical debridement of these patients should be minimum. What should do is that your patient should use the antiseptic oral mouthwashes and oral antibiotic. Particularly these agents are bacteria responds well to oral penicillin like agent, and which is quite safe to use for several weeks to get over this problem. So what about the duration of the therapy? When is this osteomyelitis of the jaw risk increases. Here's a study we published about 6-7 years ago using about 110 published papers that was available at that time. Since osteomyelitis, the joke can occur in the absence of anti-osteoporosis therapy, there's a background risk, and then the acceptable level is about twice of that, and beyond that, after about 4 to 5 years, it increases exponentially. So the first thing is to do is to remove the offending agent, the bisphosphonates or denosumab. So let's look at the drug-induced atypical subtrochanteric femoral fractures. So it's usually caused by the bisphosphonates or denosumab. Odenocative has been withdrawn from the market due to adverse effect is cathepsin B inhibitor. So glucocorticoids or hypophosphatasia can cause exactly the same kind of lesion because of the biochemical resemblance. It's a typical example of one of my patients with the typical atypical subtrochanteric femoral fracture. They get the thickened cortices and horizontal fracture, which almost never happen in osteoporotic patient. Here's what's happening in the biochemical or the causative point of view. When you label these patients with the double tetracycline taken orally, you can take the biopsy shows a double labeling tetracycline, it's lighting up. But the patient with the ONJ or atypical subtrochanteric fractures, there's absolutely no double labeling or even single labeling of tetracycline, showing that this patient has a very little or no bone formation or bone turnover near zero by over-treatment. So what about the duration of therapy for atypical subtrochanteric femoral fractures? When is the dangerous signs emerge? Similarly, these are from about 65 different publications. We summarize the data to identify the background noise. It can happen in the absence of bisphosphonates, for example, and the acceptable benefits. And beyond about age 4 to 5 years, it exponentially increases risk for atypical femoral fractures. So here's a comparison between the atypical femoral fractures, which occurs mid-shaft or under the trochanteric region, whereas the osteoporosis classical fractures are almost always oblique fractures, never happen on the horizontal. Also, look at the difference between the cortical thickness in the atypical fractures versus very thin cortices of patient who had an osteoporosis fracture. They are markedly different, and response and the response and the healing also markedly different. These fractures are not non-healing, therefore they are commonly fixed by the intramedullary rod by orthopedic surgeons, and they respond pretty well, except that these fractures are non-healing. Even after 6 months or 2 or 3 years, sometimes they remain not healing. One of the tricks we do is actually to inject locally PTH analogs, just like the teriparatide on a daily or every other day basis for 3 to 4 months. That stimulates the bone turnover locally and expedite the healing of these non-healing fractures. So one more thing about these fractures, as you see in the bird's beak, what you call the beak appearance here, and you can also see that the darker line in the middle, which shows some the cortical area has already fractures. So these patients, we should not wait till the fracture become obvious and go through and through to end up like this one on the right side. So this can be managed preferably medically by avoiding the weight bearing on that leg using the crutches strictly for 4 to 6 months and giving other bone healing components and increasing vitamin D, etc. And if possible, if available, PTH analog to local injection. Here's a much more visible partial fracture of one of my patients. You can see that the fracture has gone through halfway through the femur. So why wait till the fracture completely go through and patient become disabled and so had to go through all complication problems associated with the femoral fracture. So these should be attended as urgent, as a matter of urgency through medical means, and on some occasion getting the orthopedic surgeon to agree to put a rod, uh, rod like this one, for example, to prevent the fracture happening proactively. It's also important that somebody has the clinical signs of preeminent fractures like prodromal pain and having bisphosphonate therapy for more than 5 years to have a technetium 99 bone scan, which can actually identify the patient fracturing the bone. Alternatively, the MRI is also very sensitive. With the T1 or T2 weighted MRI, you can see the problems beforehand, before the fracture occurs, and take the appropriate steps to prevent actual fractures happening. So intramedullary roddings are indicated when there's a classical prodromal thigh pain, and the beaky and cortical thickening you see in the lateral X-rays, and other, and also the tenderness or the affected region. So when all three are present, there is impending fracture there. So you need to think about using aggressive medical treatment and or refer to orthopedics or intramedullary rodding. Similarly, if somebody already had a fracture like that, the contralateral side, when they develop prodromal symptom, one should not wait for that leg to become fractured. So need to have a proactive treatment. The other issue, actually, in our clinic, we have about 45 to 50 patients with bilateral femoral fractures due to atypical subtrochanteric fracture. Sometimes both fractures occur at the same time during the fall or rotate in the hip, and that strain is enough to break this area where there's the beaking and the microfractures occurring. So the question is, the current accepted safe limit or duration of bisphosphonate for treatment of patient with osteoporosis? Is it 3 years, 5 years, 12 years, 9 years, or is it 1 year? Indeed, as we discussed, it is 4 years, as you show the two summary slide, the fracture incidence, LS OMG, dramatically increases after the 5th year of treatment. So the reason for offering drug holidays to prevent these ONG and subtrochanteric fractures happening due to anti-resorptive are following reason, all of them except one. The answer is not to save money and improve antiresorptive therapy, but to prevent a major fracture happening and improve the quality of life and prevention of complications. So let's look at the summary of options available for preventing osteoporosis. Prevention of falls and injuries is the crucial thing to start with. And next, of course, identification of the secondary causes of bone loss and eliminating them or treating them. Weight-bearing exercises, as I said, walking probably is the best, not running, not jogging for patient with osteoporosis, and the balanced diet rich of micronutrient, including things like boron, calcium and vitamin D supplement adequacy, and if necessary, in few patients, use the appropriate medication, either osteoclast inhibitors or anabolic therapies to initiate therapy. If you decide the last option, it's crucial that you start the therapy with always with the anabolic therapy, followed by the anti-osteoclastic therapy. Otherwise, there won't be any effect, as shown in one of these above slides. So we as a physician should take proactive actions to prevent these women and men developing complications, fractures, and disabling them basically, and having premature deaths because of that. Together, we can, if we take right action, right advice, right medication, we can prevent this happening. It is, in my point of view, it is very important to remember the patient presented with one disease may have one or more other disorders. For example, for osteoporosis, the patient may be losing bone because of the hyperthyroidism, or could be multiple myeloma or hyperparathyroidism. So that's why you need to have open-minded and to look at those secondary causes, which can cause the primary reason for the patient's visit to you. Always pay attention to the history. Listen to the patient without any disruption of patient's conversation and disrupting his or her thought. This is very important, and unfortunately, few physicians had you the time to have this benefit for the patient. Engage the patient is decision making is crucial. Again, a lot of physicians don't even think about it, because if you don't get the patient involved in the decision making for the therapy, patient will not adhere to therapy. Whereas if you discuss and get the patient on board to have the particular therapy, he or she will take it seriously and do what is necessary to be done to help her. Finally, you need to take the patient as a whole, what I call the holistic way of treating patient, irrespective of the reason they're coming to see you. This is what I have been practicing for the past 40 years, and my patients are extremely happy, and that's where they're coming from. Almost like a third of the patients are coming actually from foreign patients to see me, because this attitude of taking the patient on a holistic manner and helping them. Thank you for attention, and I think we'll have questions and time for discussion. Thanks again.
Thank you, Professor Sunil Wimalawansa, for this enlightening lecture on osteoporosis management. It was rather very informative and educational. As you're a medical educator, all of us, we thoroughly enjoyed your lecture. And I must also say that I'm myself and as an orthopedic surgeon, we are at the receiving end of bisphosphonate related fractures. And but in Sri Lanka, we don't see it all that commonly as compared to how we see in other countries. But then definitely it was a enlightening, excellent talk by you. He's joined online with us for questions and answers. If anyone has questions, please go ahead.
So, hi, I'm Maheshi, another endocrinologist. So we sometimes get I have two questions. One is sometimes we do get patients who have failed on the oral bisphosphonate even after changing to IV bisphosphonate, after excluding all the secondary causes except the minor varieties of osteogenesis imperfecta where we don't have genetics. So for that kind of patients who have even failed after oral, switching to IV for 3 years, and then as we have denosumab, for how long would you recommend to use denosumab? And then following denosumab, we don't have teriparatide freely here. So are you recommending to switching over to again bisphosphonate after a course of denosumab?
I guess, thank you for the interesting question. Two areas you need to explore in this particular question. One is the failure to treatment with oral. In most cases, the failure to respond to oral is due to the non-adherent to treatment. We have found that many, many years ago, even though patients say that they're taking medication, it's not the case. However, as you said, when you switch over to the intravenous, since the physician or the nurses are giving the injection, obviously the patient are getting the medication. So assuming that patients are complying, is continuing the same medication which had been failed orally, I prefer to actually not even to convert convert it into IV. If that fails, I think something wrong in the system, either the non-responses or something else going in the body. For example, I think I did mention that the patient with the vitamin D deficiency do not respond to no matter even the intravenous bisphosphonate. So, for example, the patient's vitamin D level is less than 15 nanograms per mil, which is basically deficiency status. That will not provide the raw material necessary, which is calcium and other mineral absorption, to lay out the bone, which is necessary to improve the bone mineral density. So clearly they need to address the other areas which you may or may not have missed from patient point of view, rather than continuing the same medication which has already been failed. Thank you.
So my question was whether if we are giving denosumab following that after maybe 2 years, and so they didn't want to switch off, like we can't be giving denosumab for a long period, or else ideally we have to convert to teriparatide. But in the we don't have teriparatide here. So my question is whether can we again change over to bisphosphonate in our setup?
Sure. Let me answer the second part. Firstly, even if you have a teriparatide or the abaloparatide diet, even if you give the higher doses, the patient are not going to respond to treatment when the bone turnover is almost very, very low after several years of treatment with the bisphosphonate. So it's bound to fail. Only very few patients will respond to teriparatide after a prolonged course of the bisphosphonate. Denosumab might be different. Denosumab, the half-life is just over the 6 months. So when you stop denosumab, the effectiveness of the bone suppression quickly overcome. Therefore, those patients can be treated with the teriparatide, but not those who are treated with the intravenous bisphosphonate. Now, giving drug holidays are essential to prevent those two major complications. Osteonecrosis, the jaw, and the dreaded hip fractures, but not necessarily the hip fracture risk reduces immediately after stopping the medication, obviously, because the chemicals are lasting in the skeleton for years to come. So it takes several years to wash out the bisphosphonate, except in the case of residronate, which comes out within a year. So for us to expect that it to bone turnover back to normal even a year or two, or even in 3 or 4 years, is, I think, is false. That really doesn't happen in majority of the patient. Finally, giving the intravenous bisphosphonate, as I think I did mention it during the talk, it's absolutely not necessary, especially the Asian population, to give on a yearly basis. It's really overkilling. Many of my Asian patients with the low BMI or and the low frame, basically skeletal frame, are getting bisphosphonate intravenously on a once in 2 or perhaps once in 3 year duration. And therefore, thereby also not only reducing the cost, you really can avoid the dreaded adverse effects. Thank you.
Second one is, you said that for the prevention of osteoporosis in postmenopausal women, you recommend the calcium of 500. But in our Sri Lankan setup, most of the time, if you take a person with the dietary intake might be even less than 100 or 200 maybe. So even in that context, in Sri Lankan context, what would you recommend? Maybe 2 tablets a day, 100? As the dietary intake is around 1.2?
You're absolutely right. Actually, average dietary intake in actual Sri Lankan is in the range of about 400 milligrams per day. But the total requirement of the calcium for postmenopausal women is close to 900 to 1,000 milligrams per day. So, but on the other hand, you should not overkill by giving too much calcium also. So several studies and meta-analysis have shown that giving anything more than 1 gram of additional calcium per day could be counterproductive with the soft tissue calcification. Although most of these studies come from the single group in New Zealand, and there are other people actually dispute those meta-analysis kind of saying that they are highly biased way of analyzing, excluding some of the papers which are showing the exact opposite. So to answer your question, giving two tablets of calcium is not harmful in our situation in Sri Lanka, as you absolutely correctly said, because the dietary calcium is low. Third factor you need to keep in mind, actually, if you correct the vitamin D deficiency, and if you maintain the serum 25-hydrox vitamin D level above 30, preferably close to 40 and 50 nanograms per mil, then giving anything more than 1 tablet of calcium is actually could be harmful. So you have to keep in mind on the both sides, because when the calcium serum 25-hydrox level are above 30, and particularly the 40 and 50, your fractional calcium absorption almost double. Therefore, even with the 400-500 average calcium intake, patient will have an ample amount of calcium will get absorbed for the need of the patient. Great question. Thank you.
Thank you very much for that question. And since we are running short of time, we'll have to hand over the podium to next speaker. Thank you, Professor Wimalawansa. Thank you again.
Thanks for listening. Take care.